The next speaker is Prerna Garg, a case of kerato, irido, lenticular dysgenesis.
Good evening, everyone. So this is a case of actually bilateral congenital corneal opacity. A case of bilateral congenital corneal opacity. A child presented at 10 days of birth with high IOP in both the eyes, along with a diffuse corneal opacity with central clearing present in the right eye. The child also had a ill-defined telangiectatic patch on the forehead, and IOP was high in both eyes. On B scan, both eyes had a normal lens echo. Retina was attached and choroid and optic nerve was shown to be normal. On asking the history, it was a full-term cesarean delivery with normal birth weight, no history of delayed crying or NICU stay. The child was started on a combination of 2 drops twice a day in both eyes and planned for EUA once she attained 4 kg weight. So after a month, EUA was done. IOP was found to be still high on 2 AGMs. The horizontal corneal diameter was 11 mm in both eyes, which is high, which is more than what is expected for her age. Axial length was 23.4 mm in the right eye and 23.7 in the left eye. In the right eye, she had a diffuse paracentral opacification with central 3 mm clearing. Left eye, there was very less clearing in the center. Opacification was similar to the right eye. So left eye trapless trap was done in the same sitting, and in the right eye, the anti-glaucoma medication was stepped up. On follow-up visits, she was followed up in the OPD because repeat GA was not done, as her IOP was controlled in the left eye, and we could see the bleb in the OPD itself. In the right eye, she had a IOP was controlled on the 3 anti-glaucoma medications till the next 4 months, after which there was 1 high reading. So repeat EUA with UBM was planned. And in the right eye, we found that the horizontal corneal diameter had increased from 11 mm to 13 mm, and also the axial length had increased by 2 mm. IOP was uncontrolled on 3 AGMs, which was done by eye care. In all the settings, it was done by eye care. Whereas in the left eye, the horizontal corneal diameter and axial length was same. UBM was done in the right eye. There was a central clearing which was seen, so the lens could be seen. There was corneal lenticular adhesions. Corneal lenticular adhesions were present, but the central cornea appeared normal. Whereas in the left eye, there were only corneal irido adhesions, which was seen. There was very little antechamber present, but no corneal lenticular adhesion could be seen. So right eye trapless trap was done on the same sitting. And so diagnosis of right eye type 2 Peters anomaly and left eye type 1 with both eyes early onset glaucoma was made. Pedigree analysis was done, which was sporadic in onset, and she was referred to a pediatrician for evaluation. That was at 8 months. So she had developmental delay and was counseled for physiotherapy. Also, she was referred to the visual response clinic and advised visual stimulation exercises. The unique findings in our case included the telangiectatic patch, which was like a portwine stain or an hemangioma, which is now it is decreasing in intensity. And also in Peters anomaly, it has been found that characteristically there is a posterior stromal defect which should be present, which was not present in our case. The posterior cornea seemed completely normal in both the eyes. So Peters anomaly can be Peters type 1 or 2. Both can be associated with systemic associations and glaucoma. And coming to the Kenishal classification, he has said that instead of corneal opacity, it should be classified as a kerato irido lenticular dysgenesis, which has different categories. So in our case, the patient had iridocorneal adhesions, with the right eye having maybe corneal lenticular adhesions also. UBM is important in these cases to diagnose the anterior segment behind the cornea. And glaucoma affects 50 to 70% cases of Peters anomaly, with the elevated IOP being either from trabecular dysgenesis or angle closure from the iridocorneal and corneal lenticular adhesions. And GDDs are supposed to have a higher success rate, but in our case, since the superior conjunctiva was normal, we first thought of doing a trapless trap in both the cases, and they are working wonderfully. For the last 1 year, we've been following up, although they're supposed to have a less success rate. Thank you.
You mentioned about some telangiectasia on the skin.
Yes, yes.
So is that seen in Peters anomaly? Or
no, it's not been reported as such in literature, a presence of a portwine stain or a hemangioma. So, but it is most probably a hemangioma because it is decreasing in intensity without any treatment. So no treatment was given for it, no propranolol or anything, but it is decreasing in intensity with age. But it has not been reported with Peters.
Okay. Follow-up has been of 3 to 4 months.
1 year now.
Okay, 1 year, and pressures are controlled. Okay, thank you. I think it was Prerna. Thank you, Dr. Prerna.